The medieval plague doctor represents one of history's most haunting professional figures, forever immortalized in their distinctive black leather robes and grotesque beaked masks. These physicians emerged during the 14th century as Europe faced the most devastating pandemic in recorded history, the Black Death. Between 1347 and 1351, this plague killed an estimated 75 to 200 million people, wiping out 30 to 60% of Europe's population. While modern interpretations often romanticize these doctors as brave healers battling against impossible odds, the historical reality reveals a profession characterized by futility, danger, and profound personal suffering. The position of plague doctor was typically a municipal appointment, created by desperate city authorities who needed someone to attend to the growing masses of plague victims. These physicians were contracted specifically to treat plague patients, regardless of the patient's ability to pay. This arrangement might appear humanitarian, but it effectively created a medical death sentence disguised as public service. The very nature of their work required constant, intimate contact with the most lethal disease known to medieval Europe, at a time when medical understanding was fundamentally flawed and protective measures were largely ineffective. To comprehend the true horror of being a medieval plague doctor, one must first understand the profound scientific ignorance that dominated the medical profession during this period. The concept of germ theory would not emerge until the 19th century, leaving physicians to operate under catastrophically incorrect assumptions about disease transmission and causation. The prevailing medical theory of the time was based on the ancient Greek concept of miasma, which attributed disease to bad air or noxious vapors emanating from rotting organic matter, stagnant water, or other sources of foul odors. This miasma theory led to treatments and preventive measures that were not merely useless, but often actively harmful to both patients and medical practitioners. Physicians believed that if they could counteract the poisonous vapors with pleasant scents and purified air, they could prevent infection and cure disease. This fundamental misunderstanding of pathology formed the basis for virtually every aspect of plague medicine, from protective equipment to therapeutic interventions, ensuring that plague doctors operated under a framework guaranteed to fail. The plague doctor's iconic costume exemplifies the tragic inadequacy of medieval medical knowledge. The full ensemble consisted of a long, black leather or wax canvas robe that extended from neck to ankle, designed to create a barrier between the physician and the contaminated environment. Over this, they wore leather gloves, boots, and a wide-brimmed hat that identified their profession from distance. The most distinctive element was the beaked mask, typically made of leather and featuring glass eyepieces and a curved beak extending 6 to 8 inches from the face. The elongated beak served as a primitive air filtration system, stuffed with aromatic herbs, spices, and other substances believed to purify incoming air. Common fillings included rosemary, thyme, lavender, mint, roses, cloves, cinnamon, dried petals, juniper berries, ambergris, and various other fragrant materials. The theory held that these pleasant scents would neutralize the poisonous miasma responsible for plague transmission. Some doctors also included straw or sponges soaked in vinegar or other acidic substances, believing these would provide additional purification. In reality, this elaborate costume provided minimal protection against the actual modes of plague transmission. Bubonic plague, the most common form during medieval outbreaks, spreads primarily through flea bites from infected rodents. Pneumonic plague, the more rapidly fatal respiratory form, transmits through airborne droplets from infected individuals. While the leather garments might have offered some limited protection against flea bites, the mask's aromatic filtering system was entirely useless against bacterial pathogens. The costume's psychological impact on both wearer and observer often proved more significant than its protective value. The practical problems created by this protective equipment were substantial and dangerous. The leather ensemble was extremely heavy, often weighing 20 to 30 pounds, making movement exhausting and cumbersome. The material was hot and poorly ventilated, causing heat exhaustion during warm weather and providing inadequate insulation during winter outbreaks. The masks severely restricted vision, reducing peripheral sight and making it difficult to navigate stairs, doorways, and cluttered sick rooms safely. Communication became nearly impossible, as the mask muffled speech and prevented patients from seeing facial expressions or lip movements. These practical limitations led to frequent accidents and medical errors. Plague doctors struggled to perform delicate procedures while wearing thick leather gloves and peering through small glass eyepieces. They knocked over medicine bottles, stumbled on uneven floors, and sometimes injured patients during examinations due to their restricted mobility and vision. The inability to communicate clearly led to misunderstandings about symptoms, treatment instructions, and patient needs, further reducing the effectiveness of medical interventions. The psychological impact of wearing this intimidating costume cannot be understated. Plague doctors became living symbols of death and despair, their arrival in a neighborhood signaling that the situation had become desperate. Children would scream and flee at the sight of their approach, while adults would cross themselves and whisper prayers for divine protection. This reaction was not entirely irrational, as the appearance of a plague doctor often did coincide with mass mortality and social collapse. The social isolation experienced by plague doctors extended far beyond their working hours. Even when not wearing their professional costume, they were recognized and avoided by community members who viewed them as contaminated and dangerous. Many were prohibited from entering churches, markets, taverns, and other public spaces during active outbreaks. Some communities required plague doctors to carry bells, staffs, or other identifying markers to warn people of their approach, similar to the treatment accorded to lepers and other social outcasts. This ostracism was particularly devastating for physicians who had previously enjoyed respected positions in their communities. Many plague doctors had been successful general practitioners with established patient bases and social connections before accepting municipal plague contracts. The transformation from respected healer to feared pariah represented a complete social death that accompanied the very real risk of physical death inherent in their work. The medical treatments available to plague doctors were not only ineffective, but frequently accelerated patient mortality. Bloodletting was considered the primary therapeutic intervention, based on the ancient Greek theory of humoral imbalance popularized by Galen and other classical authorities. According to this theory, disease resulted from an excess of one of the four bodily humors: blood, phlegm, yellow bile, and black bile. Plague was typically attributed to an excess of corrupt blood that needed to be drained from the body to restore balance. Plague doctors would make incisions in patients' arms, necks, or other locations, allowing blood to flow into bowls or basins. Alternatively, they applied leeches to draw blood more gradually. These procedures were performed on patients who were already severely weakened by infection, high fever, and dehydration. The additional blood loss frequently pushed patients into hypovolemic shock, causing circulatory collapse and rapid death. Modern medical understanding recognizes that plague patients desperately needed fluid replacement and supportive care, making bloodletting particularly counterproductive. Purging through induced vomiting and diarrhea represented another standard treatment that worsened patient outcomes. Doctors administered various emetic and laxative substances to force the expulsion of supposedly corrupt humors through the digestive system. Common purgatives included wormwood, aloe, rhubarb, and various mineral salts that caused violent gastrointestinal reactions. Patients who were already struggling with fever, dehydration, and systemic infection were subjected to additional fluid loss and electrolyte imbalances that further compromised their survival chances. The surgical procedures performed by plague doctors were equally harmful and often more immediately dangerous than the internal treatments. The most common surgical intervention involved lancing buboes, the swollen and painful lymph nodes characteristic of bubonic plague. Doctors believed that cutting open these swellings would allow the disease to drain from the body, similar to draining pus from an abscess. In reality, this procedure was excruciatingly painful for patients and created open wounds that frequently became infected with secondary bacteria. The instruments used for these procedures were rarely cleaned between patients, as the concept of antisepsis was unknown to medieval medicine. Knives, lancets, and cautery irons moved from patient to patient, carrying bacteria, viruses, and other pathogens that caused additional infections. Some patients who might have survived the plague itself died from iatrogenic infections introduced during medical treatment. The lack of anesthesia meant that these procedures were performed on fully conscious patients, adding psychological trauma to physical agony. Cauterization represented another common surgical approach, based on the belief that burning infected tissue would destroy the disease. Plague doctors used heated irons, boiling oils, or caustic chemicals to burn buboes, skin lesions, or other affected areas. This practice caused severe burns, destroyed healthy tissue along with infected areas, and created painful wounds that often became gangrenous. The shock and pain from cauterization sometimes killed patients outright, while survivors faced weeks or months of additional suffering from burn injuries. The pharmacological treatments employed by plague doctors relied on an eclectic mixture of classical texts, folk remedies, and medieval innovations that were uniformly ineffective and often toxic. Theriac, a supposed universal antidote containing dozens of ingredients, including viper's flesh, was considered the gold standard of plague treatment. This expensive concoction was believed to neutralize all poisons in the blood and restore bodily balance. The preparation of theriac required months of fermentation and aging, during which the various organic components decomposed and potentially developed harmful bacteria or fungi. Mercury-based treatments were particularly popular and particularly dangerous. Doctors prescribed various mercury compounds as internal medicines, believing that this heavy metal could purge corrupt humors and restore health. Patients were given mercury pills, mercury-infused wines, or mercury ointments that were absorbed through the skin. These treatments caused mercury poisoning, which produced symptoms including kidney failure, neurological damage, and death. The similarity between some mercury poisoning symptoms and plague symptoms sometimes led doctors to believe their treatments were working when they were actually observing the effects of heavy metal toxicity. Arsenic, lead, and other toxic substances were also commonly prescribed as plague remedies. These materials were expensive and difficult to obtain, leading some unscrupulous apothecaries to substitute cheaper but equally dangerous alternatives. The lack of standardized dosing meant that patients received unpredictable amounts of these poisons, sometimes surviving due to ineffective doses and sometimes dying more rapidly than they would have from plague alone. The working conditions faced by plague doctors were absolutely horrific by any standard. Their daily routine involved traveling through plague-stricken neighborhoods where normal social structures had completely collapsed. Streets were littered with corpses that lay unburied for days or weeks, creating breeding grounds for additional diseases and attracting swarms of rats, flies, and other disease vectors. The stench of death and decay was overwhelming, even with aromatic masks, and many doctors reported persistent nausea and loss of appetite that compromised their own health. Houses visited by plague doctors were typically overcrowded, poorly ventilated spaces where entire families lay sick or dying together. Sanitation was non-existent, with human waste, vomit, and other bodily fluids covering floors and furnishings. Windows were often sealed shut based on the belief that night air was particularly dangerous, creating stifling, fetid environments that promoted disease transmission. Plague doctors had to navigate these hazardous spaces while wearing heavy, restrictive clothing that limited their mobility and vision. The sheer scale of death during major plague outbreaks meant that doctors encountered human suffering on a level that few professions in history have matched. They witnessed entire families dying within days of each other, leaving behind orphaned children who would likely die soon themselves. Pregnant women delivered stillborn infants or died in childbirth, leaving plague doctors to deal with both maternal and infant corpses. The elderly suffered particularly agonizing deaths, often abandoned by younger family members who had fled or died earlier. The emotional and psychological toll of constant exposure to mass death and suffering proved devastating for medieval plague doctors. Modern understanding of trauma psychology recognizes that repeated exposure to death, particularly the deaths of people one is trying to help, creates profound psychological damage. Medieval plague doctors experienced what would now be diagnosed as post-traumatic stress disorder, chronic depression, and various anxiety disorders. But the medical understanding of mental health was virtually non-existent during their era. Many plague doctors reported persistent nightmares, intrusive thoughts about dead patients, and an inability to experience normal pleasures or emotions. Sleep became elusive as their minds replayed the day's horrors, while waking hours brought the anticipation of more suffering to witness. Some doctors developed a condition resembling what modern medicine calls secondary traumatic stress, experiencing symptoms similar to those of plague victims even when they remained physically healthy. This psychological deterioration often impaired their judgment and effectiveness, creating a downward spiral of professional inadequacy and personal despair. The constant stress and fear took a severe physical toll as well. Chronic elevation of stress hormones suppressed immune function, making plague doctors more vulnerable to the very diseases they were treating. Many developed gastrointestinal problems, cardiovascular issues, and other stress-related ailments that shortened their careers and lives. The combination of poor nutrition, inadequate sleep, and chronic psychological stress created optimal conditions for physical and mental breakdown. Substance abuse became a common coping mechanism among plague doctors, though it was not recognized as such during the medieval period. Many turned to alcohol, opium-based medicines, or other psychoactive substances to numb their emotional pain and help them sleep. These substances often interacted dangerously with the toxic treatments they prescribed for patients, sometimes causing doctors to poison themselves inadvertently while attempting to demonstrate the safety of their remedies. The record-keeping responsibilities imposed on plague doctors added another layer of psychological burden to their already overwhelming workload. Municipal authorities typically required detailed documentation of patient visits, symptoms observed, treatments administered, and outcomes. This bureaucratic requirement forced doctors to repeatedly confront and document their failures, creating written records of every patient death and unsuccessful treatment. The act of writing these reports served as a daily reminder of professional inadequacy and personal helplessness. These medical records also served legal purposes that created additional stress for plague doctors. Families sometimes blamed physicians for patient deaths and sought financial compensation through legal action. The detailed treatment logs that doctors were required to maintain could be used as evidence in these proceedings, creating a situation where thorough documentation increased legal vulnerability. Some doctors began keeping less detailed records to protect themselves legally, which ironically reduced the quality of medical care and historical understanding of plague treatment. The educational background required to become a plague doctor represented years of expensive training that proved not only worthless, but actively counterproductive in practice. Most had studied at universities where medical education was based entirely on classical texts, particularly the works of Galen, Hippocrates, Avicenna, and other ancient authorities. These texts contained fundamental errors about anatomy, physiology, and disease causation that had been perpetuated for centuries without empirical verification. The classical medical education system discouraged observation and experimentation, instead emphasizing memorization of ancient authorities and logical deduction from established principles. This approach prevented doctors from recognizing the obvious ineffectiveness of their treatments or developing new approaches based on observed results. Many plague doctors continued applying treatments that they had witnessed fail repeatedly, simply because these treatments were endorsed by respected classical sources. The university training also created a social and intellectual barrier between plague doctors and potentially useful folk remedies or practical approaches developed by common people. Educated physicians often dismissed empirical observations made by midwives, herbalists, or other non-university trained healers, even when these observations were more accurate than classical medical theory. This academic arrogance prevented the integration of practical knowledge that might have improved treatment outcomes. The financial aspects of plague medicine created perverse incentives that compromised patient care and the doctor welfare. Municipal contracts varied widely in their compensation structures, with some providing steady salaries and others paying only per visit or per patient treated. The per-visit payment system encouraged doctors to see as many patients as possible while spending minimal time with each, reducing the quality of examinations and increasing the risk of misdiagnoses or inappropriate treatments. During major outbreaks, when demand for plague doctor services was highest, many physicians worked 16 to 18 hours per day for weeks or months without adequate rest. This exhausting schedule impaired their judgment, increased the likelihood of medical errors, and accelerated their own physical and mental deterioration. The pressure to generate income during peak plague periods often prevented doctors from taking necessary precautions for their own health and safety. The irregular nature of plague outbreaks created unpredictable income streams that made financial planning nearly impossible. During plague-free periods, many doctors struggled to maintain their practices as other medical professionals and potential patients remained suspicious of anyone associated with plague treatment. Some were forced to travel constantly from city to city, following plague outbreaks wherever they occurred and living essentially as medical nomads without stable homes or community connections. The social dynamics within plague-affected communities created numerous additional challenges for these physicians. Desperate families sometimes threatened or physically attacked doctors when their loved ones died, projecting their grief and anger onto the most visible representative of failed medical intervention. These attacks occasionally resulted in serious injuries or deaths among plague doctors, adding physical violence to the already substantial occupational hazards they faced. Conversely, some families developed unrealistic expectations for medical intervention, believing that the presence of a university-trained physician guaranteed recovery. When patients died despite treatment, these families felt betrayed and deceived, leading to accusations of malpractice, incompetence, or even intentional harm. The legal systems of medieval cities were often ill-equipped to handle these disputes fairly, sometimes ruling against doctors based on emotional testimony rather than medical evidence. Religious tensions complicated plague medicine in numerous ways that increased stress and reduced effectiveness for practicing physicians. Many clergy members viewed plague as divine punishment for collective or individual sins, opposing medical intervention as interference with God's will. Some religious authorities argued that attempting to cure plague demonstrated a lack of faith in divine providence and might actually increase God's wrath against the community. These theological objections sometimes prevented plague doctors from accessing patients or providing treatments that might have been helpful. In some cases, religious authorities actively discouraged families from seeking medical care, preferring prayer, penance, and spiritual preparation for death. The conflict between medical and religious approaches to plague created ethical dilemmas for doctors who were often deeply religious themselves and struggled to reconcile their faith with their professional responsibilities. The physical demands of plague medicine were extraordinary and took a severe toll on practitioners' health and longevity. The heavy protective clothing had to be worn for hours at a time while walking miles through affected neighborhoods, climbing stairs in multi-story buildings, and performing medical procedures that required precision and stamina. The leather garments trapped body heat and moisture, causing dehydration, heat exhaustion, and skin problems that often became infected. The restricted breathing caused by the beaked masks led to chronic respiratory problems among many plague doctors. The aromatic substances packed into the masks sometimes caused allergic reactions, while the leather and other materials degraded over time and released particles that were inhaled during long periods of wear. Some doctors developed what would now be recognized as occupational asthma or other respiratory conditions related to their protective equipment. Equipment maintenance presented ongoing challenges that consumed time, money, and energy that doctors desperately needed for patient care and personal recovery. The leather costumes required regular cleaning, repair, and replacement of components. The aromatic materials in the masks needed frequent refreshing, as their scents faded and their supposed protective properties diminished. Medical instruments became contaminated through use and required cleaning with primitive methods that were often ineffective at removing dangerous pathogens. The seasonal patterns of plague transmission created additional difficulties for doctors' professional and personal lives. Plague outbreaks typically peaked during warmer months when flea populations were most active, but they could occur at any time of year and often lasted for months or even years in major urban areas. This unpredictability made it impossible for doctors to plan their lives around plague medicine, as they never knew when they might be called to serve or how long an outbreak might continue. Family life became virtually impossible for most plague doctors due to the constant risk of bringing infection home to spouses and children. Many chose to live in temporary accommodations during outbreaks, isolating themselves from their families for months at a time. This separation created emotional strain for all family members and often led to marital problems, estrangement from children, and eventual family dissolution. The spouses and children of plague doctors faced their own forms of social ostracism and discrimination that extended beyond the period of active plague treatment. Community members often viewed these family members as permanently contaminated or dangerous, affecting their ability to participate in social activities, conduct business, or form relationships with others. Children of plague doctors sometimes faced harassment or exclusion from schools and peer groups, creating lasting psychological damage. The legal liability faced by plague doctors was substantial and unpredictable, varying widely between different cities and legal systems. In an era when medical malpractice concepts were poorly defined and inconsistently applied, physicians could be held responsible for patient deaths based on arbitrary or superstitious criteria. Some communities required plague doctors to post bonds or provide financial guarantee for their services, creating economic risks that compounded the physical and emotional dangers of their work. The primitive understanding of disease progression and prognosis meant that plague doctors often made incorrect predictions about patient outcomes, leading to accusations of incompetence or deception. They might declare patients recovered when they were actually entering a terminal phase, or, conversely, they might predict death for patients who subsequently recovered spontaneously. These diagnostic uncertainties created legal vulnerabilities and undermined professional credibility within communities that were already suspicious of medical intervention. The rapid spread of plague during major outbreaks meant that plague doctors frequently became infected themselves, despite their elaborate protective measures. The mortality rate among plague doctors was significantly higher than among the general population, making it essentially a form of professional suicide disguised as public service. Those who survived major outbreaks often emerged physically weakened, psychologically traumatized, and socially isolated, unable to resume normal medical practice or personal relationships. Communication difficulties created by the plague doctor's costume led to frequent misunderstandings, medical errors, and patient dissatisfaction that complicated treatment and increased legal risks. The mask muffled speech and prevented patients from seeing facial expressions, making it difficult to convey empathy, gather accurate medical histories, or provide clear instructions about treatments and self-care. These communication barriers prevented the development of therapeutic relationships that might have provided psychological comfort, even when medical treatments were ineffective. The limited diagnostic capabilities available to medieval physicians meant that plague doctors often confused plague with other diseases, leading to inappropriate treatments and missed opportunities for effective intervention. Typhus, smallpox, and various other infectious diseases could present with similar symptoms during their early stages, but they required different treatment approaches and had different prognosis. The plague doctor's focus on plague-specific treatments sometimes prevented recognition of conditions that might have been more successfully managed with available medieval remedies. Supply chain disruptions during plague outbreaks made it difficult for doctors to obtain necessary medicines, instruments, and protective equipment. Trade routes were often closed, markets shut down, and production of medical supplies halted as craftsmen and merchants fled affected areas or died from disease. Plague doctors frequently found themselves working with inadequate, improvised, or substitute materials that reduced their effectiveness and increased their personal risk. The cumulative effect of all these factors made the profession of plague doctor one of the most difficult, dangerous, and ultimately futile occupations in medieval society. These physicians faced a perfect storm of medical ignorance, inadequate protection, social stigma, psychological trauma, and near certain death or disability. Their noble intentions to serve their communities during times of crisis were systematically undermined by every aspect of their professional environment, creating a tragic example of how good intentions and personal courage cannot overcome fundamental systemic failures in knowledge, technology, and social support.